Next. Meet Gray, a 1.5 years old domestic short-hair castrated male, weighs 3.6 kg, was managed indoor and kept with one other cat at home. He was been fed with kibbles and wet food. The vaccination, deworming, and ectoparasitic control were not up to date. So as for the history, on 11th October 2021, the owner brought him to private vet with a primary complaint of inappetence and reducing body weight. He had previous episodes of recurrent stomatitis. Upon physical examination, he was pyrexic with pale mucous membrane and without distended abdomen. The hemogram reveals non-regenerative anemia, high normal lymphocyte count, and borderline thrombocytopenia. In serum biochemistry, there was an evidence of hyperproteinemia due to hyperglobulinemia with A to G ratio of 0.3. The feline coronavirus immunochrome test reveals S5 high positive reaction, indicating greater likelihood of FIP. So the vet's tentative diagnosis is dry form FIP. The next day, Gray was referred to UVH for further diagnosis and treatment. Upon physical examination, he was pyrexic with normal respiratory and heart rate. He was quiet, alert, and responsive with body condition score of 2 out of 5. His mucous membrane was pale with CRT less than 2 and skin tan less than 2 seconds. So the first problem list is non-regenerative anemia with a differential diagnosis of feline infectious peritonitis, hemotropic mycoplasmosis infestation, and FELV and FIV. Next is thrombocytopenia and differential diagnosis of feline infectious peritonitis and FELV FIV. The following pale mucous membrane, pyrexia, and inappetence could be due to problem number 1. So the plan is to perform PCV, PP, FELV, FIV test, abdominal radiograph, and abdominal ultrasound. So the PCV finding was 19% and plasma protein was 94 gram per liter. And the FELV, FIV test turned out to be negative. And moving on with abdominal radiograph, the VD view. The VD view shows left kidney enlargement indicating renomegaly. And the lateral view, we can see the liver is extended beyond the costal arc, indicating hepatomegaly, and there is increased soft tissue opacity within the bowel, suggesting physis.
Moving on to the abdominal ultrasound. Here is the ultrasound of the liver, and we found irregular shape of the liver with diffuse hyperechoic region within the liver, with diagnosis of hepatomegaly. Next is the spleen. The spleen shows hyperechoic, particularly at the ventral part, indicating splenomegaly. Next, this is bladder. There is no any significant finding in the bladder. Next is however, there are free fluid accumulation in the abdomen, indicating peritoneal effusion. So, the updated problem list was next, peritoneal effusion with differential diagnosis of FIP and abdomen, and number 6 is hepatomegaly, which is a differential diagnosis of feline infectious peritonitis, and we plan to do abdominal synthesis and also Revolta test. Next, so the tentative diagnosis for this case was suspected feline infectious peritonitis, and for the treatment, for this case, first is suspected feline infectious peritonitis, so we treat with the prednisolone at 1 mg per kg, half tab, and given orally, SID for 3 days as anti-inflammatory, and also ranitidine 0.3 ml IV once a day for 3 days, also for gastric protectant. And as for paresthesia, We give tramadol at dosage 3 mg per kg and dose of 0.22 ml subcut twice a day for 3 days as analgesic. And for inaptitudes, we give IV fluid at maintenance rate was given to promote hydration and phosphate was done TID for 3 days. As for prognosis, in this case is poor because the cat is slowly developing the wet form of FIP with the evidence of peritoneal effusion. Only supportive treatment can be done at this point of time. Next, the cat was discharged on the 14th October. Upon discharge, he was prescribed with cimetidine, prednisolone at 1 mg per kg and B complex. He also was KIV to come back for tube placement and other supportive treatment. Next, as for client education, the owner need to provide adequate litter box in the multiple cat household as FCOV positive cat can share the virus. Owner also need to isolate the cage, litter and the bowl of FECOV positive cat from other cats in the multi-cat household. Medication need to be continued even though the clinical signs are improving, and the owner need to bring the cat as soon as possible if abdominal bleeding and dyspnea are observed. And lastly, practice a good hygiene can help in the management. So that's all from us. Thank you.
Hi, any question from students? Right, so if not, well, okay, shall we, Dr. Chan?
Good morning, Dr. Chanwei. So your question is, how does providing adequate litter box help to prevent shedding of feline coronavirus in multi-cat household? So we all understand that feline infectious peritonitis is a mutated version of feline coronavirus. So also, FIP is not contagious and feline coronavirus is contagious. So since it is contagious, if we provide adequate litter box, the cat don't have to share their litter box, and by doing so, they don't have the exposure to this virus. So yeah, doctor. I hope I answer your question.
Right. So how does tramadol treat pyrexia?
Dr. Intan. So to answer your question, normally tramadol is an analgesic, but it also reduces the vasoconstriction and has a three major thermoregulatory responses.
Right.
It's used to relieve the pain and also reduce the fever, Dr. Intan.
So to relieve pain and
Also to reduce fever.
fever.
It has a thermoregulatory response in it, doctor.
Okay. So sorry, this is new to me. Could you produce a reference?
All right, doctor. I'll mail to you.
Because as far as I know, well, at least not in UVH, we don't treat pyrexia, especially pyrexia, with tramadol. Okay, so there's there's sort of like a reason for that. If you said that, well, reducing temperature is one thing, but for pyrexia, you have to find the cause and treat it. So hypothermia, probably, you know, but again, this is not something that I am aware of. So if you could produce a reference, I think I would appreciate it. And I would like to know if this is routinely done in other parts of the world. And then the other thing that you are missing in the client education is, well, it's nice when you put, you know, all those general information, but what do you think the owner wants to know the most when it comes to FIP?
I believe that owner should know that there is no cure for
Sorry, you're breaking up. I cannot hear you.
FIP and available.
Sorry, I cannot hear you.
Doctor, is it clear now?
A little bit better, but still soft.
Doctor, can you hear me now? I believe that owner should know that there is no cure for FIP and there's only supportive treatments available. And also, if they have a
Well,
at home.
still sorry, I'm not sure whether it's just me, but I cannot hear you at all. You sound like you sound very soft, and I cannot hear anything.
Yeah, it's still breaking.
Yeah, still breaking.
Doctor, can you hear me now?
Yes,
Sounds
better.
better.
I believe the owner also want to know the status for other cats. As for but FIP cannot be it's not a contagious. But then the owner I think the owner wants to know the status of if the other cats can develop FIP also. So I think FECOV test need to be done for other cats in the house so that the owner should know the status in the house.
Yeah, well, it's sort of like interesting when you bring that up. That didn't answer my question, no. How, so you were suggesting that by doing FCOV tests would tell you whether the cat will develop FIP or not?
So actually, doctor, for FCOV, even if there is one cat having FIP, doesn't mean that the other cat at home will develop FIP as well. But because this is not contagious, but for FCOV, it is contagious. So it means if the other cat has FCOV, the other cat maybe will have FCOV as well. But it is not necessarily that it will mutate to FIP, doctor.
Yeah, so that's the thing. So FCOV tells you about exposure. So it does not necessarily mean, or it cannot be used to predict whether cats will develop FIP or not. The point is that if you have a multi-cat household, if they mix together, there's a chance that they would have exposed to coronaviruses. So that's why I'm actually questioning if you know this theory. So why FCOV test is still valuable? Because what you will get is just, oh, well, cats have been exposed, these cats have not been exposed, that's all. Still, cats that have not been exposed, it doesn't mean that they will not be exposed to this virus in the future and will not develop FIP. Yeah, because one FCOV test will cost you around 90 ringgit. If you have 10 cats, that's going to be 900. Okay?
Yes, doctor, it doesn't necessarily to do FCOV test for the other cats because it just shows the antibody titer of coronavirus and it depends on the individual immunity whether it's going to develop into FIP, but it's not necessary to do FCOV test to the other cats also.
Yeah. So when you're suggesting something to the owner, well, being able to give a cost-effective suggestion would help you, and would help the client as well. Okay? It's not, practical for most owners, especially those that have, multiple cat household, unless they requested it, right? Can I see you, your client education again? Okay. Do you have pets? Any of you have pets at home?
Yes, doctor.
Right? You have cats, right? I'm sure. So if your cat has FIP, has been diagnosed with FIP, apart from this, well, I don't want you to repeat exactly the same thing. Apart from this, what would you interested to know? The most thing.
Doctor, I believe it is the prognosis of the cat.
Yes, you believe it is a prognosis of the cat, but yet it is not, stated here. So it's very important, very common question too. I mean, from many owners, right? So what's going to happen after this? Is my cat going to survive? How long is he going to survive? That kind of thing. So that's why client education could be very personal. And I mean, having general information is nice, but it should be tailored according to cases.
Okay, doctor.
Okay, right. Sorry, I need a peek on your differential diagnosis. Right, so non-regenerative anemia. So I assume that this came from private, is it?
Yes, doctor.
Okay. So pale mucous membrane and non-regenerative anemia is well, I think it can be grouped together because it's just, it's quite in the same category. So how does hemotrophic mycoplasmosis has non-regenerative anemia?
What's happening? Students, do you have answer?
Yeah, I don't know. What are they doing?
Doctor, because of chronic hemorrhagic mycoplasmosis infestation, there will be bone marrow suppression that leading to non-regenerative anemia.
Oh
Really?
lah.
No
I'm
lah,
sorry.
exactly.
Who taught that? Where did you read such a thing? It has no effect, hemotrophic mycoplasmas, on the bone marrow. It's completely at the level of just the RBCs. Even it's wrong that you think that feline FIP, you see thrombocytopenia, or an FELV, FIV. That's also incorrect.
Yeah, I was gonna ask about that as well. Doesn't make any sense.
Yeah, it's just kind of like you're just throwing things out there without really thinking. Thrombocytopenia, especially in cats, is it even a true thrombocytopenia? Or was it platelet clumping? Was it a true thrombocytopenia?
The blood test was done at private, and the only thing from the result was non-regenerative anemia and also thrombocytopenia.
Yeah, so that's even more so. You can't really, know whether this is true or not because nobody looked at a blood smear, right?
Yeah.
Yes,
doctor.
Yeah, so that's what you should put there. Thrombocytopenia, question mark, is it a true thrombocytopenia? Don't jump to conclusions and, and then also putting wrong differentials. That's all from me because I'm sorry I missed half of your presentation. I just had to look here.
And I'm just wondering, what is the justification for abdominal radiograph and ultrasound? Sorry, I missed the first part of the presentation as well, so I'm just wondering.
Abdominal radiograph was performed to evaluate was there any organomegaly or is there any other space occupying lesions concurrent with these conditions, and abdominal ultrasound was performed to evaluate is there any free fluid, because previously the private vet diagnosed there was no abdominal distension and there was no any fluid, but here we found out tend to be there was fluid development inside the peritoneum.
Okay, fair enough. You were saying about finding space occupying lesion, but again, you didn't mention any differentials on that. So my point here is that your diagnostic workup actually is being planned to rule out your differential diagnosis. Okay, you're not using it just to simply, fishing, and try to roll as many things as you can. So you actually plan diagnostic to rule out your differential, and I don't see any neoplasia on your list. Okay, so shall we move on?
Yes, doctor. Thank you, doctor.
A very good morning to everyone. Today we are going to present a report which is about anal sacculitis in a German Shepherd dog. Next slide. So this is Legion, 10 years old German Shepherd dog weighing about 33.4 kg, and this is a PDRM dog fed with kibbles. So as for the history, Legion had been diagnosed with anal sacculitis since 2020, and there was several recurrence episodes of anal sacculitis as in December 2020, June 2021, and October 2021, which is the current episode. So upon physical examination, TPR were within the normal range, pink mucous membrane, CRT was less than 2 seconds, and we observed wound at anal sac at both left and right side with bloody purulent discharge, as well as we have noticed wound at left flank and tubercocci. So these are the appearance of the wound that we took picture on day 3 of hospitalization. So for the problem list, first problem is wound at anal sac at both left and right side. The diagnosis is anal sacculitis, and the diagnostic workup to be done is CBC and serum biochemistry, radiography, and wound cleaning. Second is wound at left flank and tubercocci. It was due to trauma, and the plan is to do wound cleaning. So from CBC and serum biochemistry, there were no significant findings. Everything was normal. Next. Okay, and for the radiograph as well, there was no significant finding, and just obtained normal radiograph. Next. So the treatment plan for this case is first advocate 1 drop per site. We did it on day 1 as a parasiticide, as on the wound region there were maggots, and then second is wound cleaning with diluted chlorhexidine. We done it on from day 1 until day 10 to clean the wound area, and we also prescribe administer cephalazine 15 mg per kg, 1 tab POVID from day 1 until day 10 as broad spectrum antibiotic. And metronidazole 1 tab POBID from day 1 until day 10 as antibiotic against anaerobic bacteria. Serothiopepsidase 1 tab POBID from day 1 until day 10 as NSAID. And tramadol 3 mg per kg, 2 ml subcut BID from day 1 until day 10 as a mild analgesic. And we also applied topical gentamicin cream at the wound area as a topical antibiotic. So the prognosis of this case is fair to guarded. Fair because the condition of the wound improved after routine wound cleaning and administrations of medication. And guarded because this anal sacculitis may recur again if the wound care is not done properly. So this is the appearance of the wound on day 7 of hospitalization. Okay, for the update, since the wound healing is slow, so we suspect it to be anal furunculosis. And this week, Monday, we took swab sample to be sent for bacterial culture and AST, as well as we have done, we did punch biopsy to do histopathology, and the results are still pending. And that's all for this case.
Any question? Sorry, I just noticed there are more in the chat box for the other case.
Is there any question? Okay, so hi inside. So the indication for the abdominal radiograph in this case is because since we suspect it could, our diagnosis could be anal sacculitis. So for the anal sacculitis, how it happened? So anal sac, it functions to release the fluid when the dog defecates, and it should fully empty the anal sac. So in case that there is any abnormalities that causes the anal sac couldn't fully empty the anal sac, so the anal sac will become thickened with the fluid, and it leads to the anal abscess, and at the end when it ruptures, then also then how the wound develop. So in this case, we would like to know what causes the anal sac couldn't fully empty the anal sac. So that's why we do the abdominal radio, because since this is male German Shepherd dog, so we would like to know if there is any cases of the prostatitis, or is there any case of the colitis, and also if there is any foreign body that could leak to the anal sac, couldn't fully empty the fluid. Is it answer your question, Esther?
Are you really sure that those were the justification for an abdominal radiograph? Because anal sac and the abdomen region are totally not connected at all. I mean, what you have justified just now are totally not related to anal sac and the causes of anal sac infection or infection.
Okay, for this case, we were planned to take pelvic radiograph, but it happened to be abdominal. We have also included the pelvic region in that radiograph, so it's not literally of the abdominal radiograph. So we wanted to see if there is any abnormalities in the pelvic region.
What kind of abnormalities you are looking for?
So doctor, since this is male dog, so it could be because of the prostatitis. Because for the anal sacculitis, the reason why it couldn't fully empty the anal sac is remains unclear, but it could be because of the certain reasons such as prostatitis, colitis.
Okay, thank you.
Is there any more question? If not, can we move to the next case, doctor?
Sorry, the justification for that radiograph for the pelvic is actually incorrect, justified by what you have mentioned. If you're thinking about prostatitis or if you're thinking about colitis, there should be more clinical sign coming up from this dog rather than you're looking at the wound and you want to see what's the underlying. You better go back and read up about your anatomy for anal glands and think further from there. I'm sure the radiograph, if it was indicated, it must be for some other clinical sign, not what you have justified just now. Okay?
Okay,
Okay,
doctor.
doctor.
If there are no other questions, perhaps let's move to another one.
Good morning to all lecturers and all my fellow friends. Today we are going to present about thoracentesis procedure in a DSH cat. Meet Carpet, a 4-year-old spayed female domestic short hair weighing 4.6 kg with body condition score of 3/5. She was managed indoor with another 3 cats at home. The vaccination and deworming status was not up to date. So the history was she was diagnosed with pleural effusion 3 weeks ago, and thoracentesis was done, and 57 ml of straw-colored fluid was aspirated from the right pleural cavity. And 2 weeks ago, echocardiography was performed, and mass was found at both right atrium and ventricles. And yesterday, on Monday, she was presented to UVH with abdominal bleeding and open mouth bleeding. So upon physical examination, the TPR was within normal range. And however, she was dull and depressed, pale mucous membrane, and harsh lung sound was heard with profuse salivations, and the cat was having abdominal bleeding. So for the diagnostic workup, upon radiograph, there was increased radio opacity at right and left lung lobe and obscured cardiac silhouette, indicating pleural effusion. And for the right lateral view, obscured cardiac silhouette, retraction of caudal lung lobe from thoracic wall, and loss of diaphragmatic line, indicating pleural effusions. So we stabilize carpet in oxygen chamber and maintain with 3 liters per minute oxygens before we did thoracosynthesis. So for thoracosynthesis, these are the things to prepare, which are butterfly catheter, 20 ml syringe, 10 ml syringe for sampling, three-way stopper, kidney bowl, straggler, glove, clipper, and skin prep. So for the procedure, so the skin was clipped and prepared with heavy scrub, alcohol, and iodine on the thoracic region, and the cat was placed on sternal recumbency, supplied with oxygen, and sedated with propofol. And then the butterfly catheter was connected to the three-way stopper and 20 ml syringe using sterile glove in a sterile area. And the location of butterfly catheter insertion was marked at intercostal space between 8 and 9 ribs. And the landmark for butterfly catheter insertion is between 7 to 9 ribs. And the catheter was inserted perpendicularly to the skin. And as soon as the needle enters the skin, 2 to 5 ml of the vacuum was applied to the syringe and held constantly. So fluid was aspirated using 20 ml syringe, and 10 ml syringe was connected to the other end of three-way stopper to collect sample from 20 ml syringe. And the excess of fluid was aspirated and removed into the kidney bowl via the three-way stopper. So when the butterfly catheter was removing, aspiration was continued to maintain the pressure and to prevent air or fluid backflow to the lung.
So radiograph was taken immediately after thoracosynthesis, and the finding is the lung lobe seems improving, and we can see clear demarcations of the diaphragmatic line. And 290 ml of straw color fluid was aspirated from the right pleural cavity, while 9 ml of straw color fluid was aspirated from left pleural cavity. So the specific gravity for the aspirated fluid is actually 1.025. So based on the straw color fluid as well as the specific gravity, so the effusion is actually indicate modified transsudate. The tentative diagnosis for this case is actually suspected intracardiac mass. So after thoracosynthesis, the cat was placed in oxygen chamber for 5 hours, and then the cat was moved to another cage to challenge the ability to breathe without oxygen supply for 30 minutes. And within that 30 minutes, the carpet seems stable and no abdominal bleeding was observed, even after 30 minutes and up until yesterday. So the possible complications for thoracosynthesis is first is iatrogenic pneumothorax, lacerations of lung, hemothorax, as well as intercostal artery lacerations. So thoracosynthesis is contraindicated in case of severe coagulopathies, thrombocytopenia, as well as when there is only a small volume of fluid or air present. So that is all from us. Thank you.
No question from me, but I've got one feedback for you. One of your slides, you write there as backflow of fluid and air into the lung. Are you sure it's backflow of air and fluid in the lungs? Masa you tulis post-thoracentesis punya slide? Prior, I think further up. Yeah, I think this one, yes. Are you sure it's backflow of fluid or air into the lung?
It's actually to prevent air or fluid backflow to the pleural sac. It's not to the lung.
Pleural cavity pun boleh ya?
Yes, Dr. Pleural cavity.
I also have a comment. I think it's regarding the fluid characteristics. You said it's straw colored. That's not straw colored. That's just pale yellow. Okay, the reason why I'm saying this is because straw colored is very characteristic of FIP. It's more of yellow. It's more darker yellow. That's what straw colored is. So that's why you just need to be a little bit careful, because whenever you see straw colored, it's very strongly associated with FIP, but this is just very pale yellow. Okay?
Okay, Doctor.
Thank you.
Do you guys actually have an image of the echo to show the intercardiac mass? Just out of interest?
Wait, Doctor, we can share to you. This one, Doctor, the echocardiography that was done 2 weeks ago.
Where is the mass? Show us, please.
Where's the mass? Huh?
This one, Doctor, the hyperechoic structure.
No, that is not the one. Did you discuss this case with any consultant or any VO on the case?
No, Doctor.
I think you should next time if the image that you are not sure. And
Okay, Doctor. Doctor, we plan to do ultrasound today. Also.
simple case you can, but this kind of case you should discuss with the consultant or. Okay, thanks.
Okay, Doctor.
Are there no further questions or comments? If not, then we can just end the rounds.
Okay, doctor, thank
But
you.
there's just silence and we're just staring at your echo.
Okay, doctor.
Okay, thanks.
Thank you, doctor.